Hello and welcome to this Philips Volcano webinar series in association with Radcliffe Cardiology. I'm Dr. Christopher Cook, Clinical Editor for the Radcliffe webinar series, and I'm delighted to be joined live by Professor Giuseppe Tarantini, Director of the Cardiac Catheterization Laboratory at the University of Padua, Italy. Professor Tarantini is going to be talking to us today about morphological and functional evaluation for complex PCI. In particular, we will hear a comprehensive deep dive into IVUS, IFR, and IFR Scout technologies, with an emphasis on advanced real-world clinical cases. With an aging global population, patients are presenting to the catheter lab with more and more complex forms of coronary disease. Coronary physiology techniques such as FFR and more recently IFR help clinicians identify ischemia and target PCI appropriately. Since its initial introduction in 2012, there has been much excitement regarding IFR as a coronary physiology index, given that it provides similar diagnostic performance to FFR without a need for hyperemia. Furthermore, because IFR is measured under resting conditions, extended applications of IFR such as the assessment of tandem lesions, diffuse disease, and even virtual PCI capabilities are possible. Professor Tarantini is an expert in such advanced coronary physiology techniques as well as intravascular imaging. This seems like the perfect moment to welcome Professor Tarantini to the webinar, who is joining us live. Professor Tarantini, hello and welcome.
Hello. Thank you, everyone. Good afternoon, and thank you again for having me for this interesting webinar.
Thank you so much for joining us. Now, before we begin, just a quick note to our audience. You'll have the opportunity to ask Professor Tarantini questions via the text box on your screen throughout the course of the webinar, and Professor Tarantini will answer as many as possible at the end. Okay, so I'm going to stop talking now and hand over to Professor Tarantini to begin his presentation.
Okay, good afternoon, everyone. My name is Giuseppe Tarantini. I'm Associate Professor of Cardiology at the University of Padua and Chief of the Interventional Cardiology Unit in the Department of Cardiac, Thoracic and Vascular Sciences of Padua. So my task today is to discuss the advanced coronary physiology for diagnosis and treatment of complex coronary artery disease. And let's move to the first slide. I have just 3 to 4 slides of introduction just to put into the context what we're going to discuss in a clinical-based scenario. This is a very important slide, I think, and it is a sub-analysis of the COURAGE trial, in which we can see that the use of PCI plus optimal medical therapy will improve the ischemia reduction of at least 5% in 33% of the patient compared to the 20% of the patient treated just with optimal medical therapy. This difference is statistically significant, but the point is that on clinical ground, this difference is less than 15 more or less percent. That means that in 85%, the two treatments are indifferent. And so this is amazing because when we consider that we treat a patient with severe coronary artery stenosis with a PCI, should we have not only a statistical significance, but also a clinical remarkable reduction of ischemia compared to just optimal medical therapy. And why how could we explain that? I think one way to go is to think that on one hand, we can have an over-treatment of non-ischemic lesion or under-treatment of ischemic lesion. This is mainly related to 3 factors. The first one is the limited spatial resolution of non-invasive tests. The second one is the limited accuracy of angiographic PCI. And third point is severe multivascular disease. So this is one example of the limitation in terms of spatial resolution of non-invasive tests. Here you can see that we have a spec that shows a significant reversible perfusion defect in the lateral wall. And we suppose, looking at this spec, that the patient has a single vessel disease, but on the other hand, here you can see the severe 3-vessel disease And doing the FFR, we have 3 significant lesions in 3 different vessels. And it is not possible to discern by the use of non-invasive tests because of the fact what we have with respect is a relative, evaluation of the reduction of the coronary reserve in one territory that is relative to the other one. So if we have a reduction in all 3 vessels of the flow, we might see also a negative SPECT test. And this is also by literature, what we know is the SPECT demonstrated no significant perfusion defect or single vessel pattern in half of the patient with reversible disease, and the SPECT may show also balanced ischemia, yielding to uniform uptake, as I said, in up to 10% of the patient with reversible disease. So we can have a SPECT that is totally negative, and on the other hand, by angio, we might have a severe reversible disease. The second concept that is extremely important as a background is the distribution coronary resistance. As we know, the coronary circulation is a resistive circulation. It means that the vast majority of resistance is pertained to arterioles that are very distal. And the point is that with non-invasive tests, what we can measure is, the combination of the resistance offered by the epicardium and microvasculature. The only index that permits us to discern between these 2 compartments is the use of FFR or IFR, because these 2 are lesion-specific indexes. That means that only by use of these 2 indexes we can say that the the reduction in coronary flow reserve that we observe in a patient is related to the epicardium, to the epicardial part of the coronary tree instead of the microvasculature. And this is important because what we treat by PCI or CABG is just to skip, and to fix the proximal and the epicardial part of the coronary tree, not the microvasculature. That's my last concept before going to a real clinical case to share with you. This is the IFR. IFR is an evolution, I used to say evolution of the FFR. It's not just, a new way to assess the reduction of coronary flow reserve that is caused by the epicardial stenosis. It's for me an evolution. And you will realize what I mean with evolution when I show you the 3 different clinical scenarios. But sticking to the concept, to the equation, what you can see is the IFR is an instantaneous pressure ratio, PDPA, across the stenosis, during the wave-free period. In resting condition, we don't need an adenosine, we don't need maximal hyperemia, we just take this ratio during this wave-free period, that is the one in which the resistance is close to 0, a constant, and thus we have a direct relationship between pressure and flow, and the resistance is really low, the lowest value of resistance that we have during the pulse and the common heart cycle, etc. And going to the FDA labeling for IFR modality, here you can see that if we have an IFR value that is below 85, we are for sure we are looking at something that is a severe coronary artery stenosis on physiologic ground. Above 94, for sure we can exclude ischemia. Between 85 and 94, we have a gray zone. This is a gray zone just to be, because this is a new index, just to be very conservative to avoid significant mistake when we compare this value with the classic and standard value of FFR. What I'm saying is that actually we have a real cutoff value that is 0.89, but to avoid, as I said before, to be too strict in terms of definition, we leave out this zone, like gray zone, in which we need to do something more to induce a vasodilatation by adenosine, and to check twice the functional meaning of the lesion before taking a decision. So case number 1. This is the clinical history, 77 years old man, indication for carotid revascularization. The patient has a stable angina. It is a Canadian 2. This is the ECG. I'll try to, okay. This is the angio of the patient. The patient has severe coronary lesion, the proximal RCA, and a distal lesion that seems to be significant in a view of the RCA, right coronary artery. This is the left coronary artery. There is a lesion at the level of the left main. We have something at the level of the proximal mid LAD. And we have some lesion also at the level of the circ, as you can see, the proximal part of the circ. So, the point at this stage, by looking in one shot what I've said, we have a lesion on the right, on LAD. It seems to be diffuse, but it's difficult to estimate. And we have some kind of lesion at the level of the distality and proximal parts of the left main. So the point is, how would you treat and where would you stand? We can discuss, in the second session, most of this point in off-record modality, etc. But now I have to go ahead with carry on with my presentation. So I'll tell you one thing that is interesting, because this patient was referred to our center from another hospital with the following indication: PCI for left main or right coronary artery proximal part, because the patient, according to the surgeon, need to have these two lesions revascularized before going to the carotid revascularization. But the point is that we have to share if, what, and how to treat. And the point is that we did two different modalities. We have the IVUS and the physiology. The physiology we used to push towards physiology when we want to understand if and what. On the other hand, when we have already decided, to go with the PCI, we have to, pick up the IVUS to understand how to treat. But the point is that in this case, what we have is the left main. And why the left main deserves more discussion? Because the left main is the segment of the coronary artery tree that has the greatest angiographic assessment variability among all the other proximal coronary segments. And here you can see the distribution of the distribution of the diameter stenosis of left main as assessed by the control lab versus the clinical site assessment in the CAS study. What means that for the case I'm going to present to you with a left main that is between 30 to 70, there is a huge variability to assess properly the left main. What we got by the registrar is that when we have a feature like this one, with a very, very short lesion proximal at the level of the ostium, in many cases, in two-thirds of the case, what we can see is that the left main is going to be negative. Is going to be negative at the IVUS assessment. And only 1/3 of this angiographic significance is going to be confirmed by IVUS. And this is important as a take-home message, because if we do the IVUS in this case, as you can see, there is just a band, there is a small plaque within the lumen, and this is mainly due to the fact that the level of the ostium, especially where we have a very short lesion, this most of the time is just a matter of bend and not of real severe coronary arteriosclerosis. Notwithstanding, we have to admit that the IVUS is a 2A level of evidence B indication to assess severity and optimize treatment for unprotected left main, as assessed, as stated by the 2014 ECS guidelines on myocardial revascularization. And again, especially when we decide to treat the left main, is important, the IVUS, because we have this 4 magic number, 5, 6, 7, 8, that is, the minimal lumen area to finish up when we decide to stent this bifurcation lesion, proximal bifurcation lesion at the level of the left main, because it matters in terms of prognosis, as shown in this paper from Seung Park, Chinese group, Circulation Cardiovascular Intervention 2008. But let's move from the anatomy to the physiology. What we know from Michaelis and Milos is that when the left main angiography is less than 50%, in 1/4 of the patient, we still might have an FFR value that is positive for ischemia, less than 0.80. On the other hand, when the left main stenosis is really judged as severe, more than 50%, we make a mistake only 6% of the patient by affirming the fact that this lesion is significant also on functional ground. So this is a very important information. Notwithstanding, again, we need to be aware of this fact. The left main is not just a lesion. It is very rare to find out, isolate the left main. The vast majority, the left main is, a part of a severe diffuse complex and multivessel disease, calcific, distal location, and et cetera, and comorbidities like diabetes. This is the reality, in the common practice. So we need to tackle this kind of facts that when we have a lesion in the level of left main, we might have 1, 2, or 3 lesions in another vessel that is downstream of the lesion of the left main. For instance, in this slide, from being JCC intervention 2015, we might have 2 lesions, the top part of the slide, 2 lesions, left main and LAD. The fraction for the value is 84 proximally to the distal lesion and 0.60 distal to the distal lesion. But at this point, we cannot rely too much on the FFR of 0.84 because the lesion that is present downstream, the evaluation, the proximal evaluation, reduce the potential increase of flow that we induce with adenosine, because there is a restriction down the evaluation of the FFR that here in the slide is 0.84. And as a matter of fact, if you relieve the coronary circulation from this stenosis and we fix with a stent, as you can see, the FFR value used to change from 84 to 74, because when we fix the lesion that is downstream, we have the possibility to see a significant increase in flow that will translate in a significantly drop of the pressure across the stenosis. And this is a very important concept that I would like to stress again in this slide. Okay, down in the bottom part of the slide, as you can see, we have black dots between two stenosis. Okay, in the upper part of the slide, the black dots are positioned in the 2 different curves. The upper one is the apparemic flow curve, and the second one in green is the resting flow. As you can see, when you have a lesion that is downstream, we have a tandem lesion, and we make an assessment between the 2 lesions. As you can see, the resting flow and the apparemic flow, the 2 value of coronary flow is not, dramatically different. But when we fix the second lesion that stayed downstream, the first one, as you can see, the red dots, the apparemic flow increased dramatically. This means a significant pressure drop with another value of FFR. On the other hand, what remains stable is the resting flow. So this is the best background to understand that the optimal thing might be to assess the functional meaning of a stenosis, a tandem lesion or diffuse disease in resting condition, just to understand what is going to happen in the different segments of the coronary tree, besides the fact that we have multiple lesions and the need to increase and to create an hyperemia. And the last concept that is extremely important to keep in mind, that the coronary flow across a lesion, a diffuse disease in a coronary artery, is quite stable for extremely severe lesion, up to 99%, because we have, the distal vasodilatation of the microvasculature that permits to maintain stable, to keep stable the flow across the coronary artery. Yes, again, going back to the 2014 guidelines for myocardial revascularization, what we have said is that IVUS we have seen is 2A indication, and the FFR guided in patients with multivessel disease remain a 2A indication, level of evidence B, and 1A when the FFR is used to identify hemodynamically relevant coronary lesion in stable patients when evidence of ischemia is not available. But going back to the case, this is the lesion at the level of the left main, this is the assessment of the IVUS, this is the real IVUS for this real case, and as you can see, the area is not significant at all because it's 8 millimeters square, it's not 6. It is the cutoff that we use in Western country. In the East, very East country, they use 4.8 because, the body mass of the people is a little bit lower. Let's give a look at the IVUS at the level of LAD. Again, you can see diffuse disease, calcific disease, but the point is that we don't have in Vizuchar in 2016 any a paper that permits to us to understand if we have to take some decision to treat or not a diffuse disease like that one based on the fact that we have different magic number across the coronary artery tree. In other words, we don't have a cutoff value of the IVUS when we tackle patients with very diffuse. All the magic numbers that we have pertain to very small and focused lesion, not when we have a diffuse disease like the case we are discussing. And there is two other very important considerations to keep in mind, that the cutoff value of 4 millimeters square that we use commonly is totally different according to the patients we are making this evaluation, because if the body size is very small, we might have 4 millimeters square. It does not mean anything because the lesion is just 10% of lesion instead of 50% lesion when we have a very huge vessel with severe coronary artery atherosclerosis that leave out an MLA of 4 millimeters square. And again, we need to keep in mind that we cannot consider any single cutoff without taking into consideration also the reference vessel diameter. As you can see by this paper, Eurointervention 2011, from Gus Pichard, the C statistic is very good when the vessel size is larger than the reference vessel is more than 3.5. As you can see, the C statistic is 0.83, and the cutoff value is close to 4, 3.7. When the reference vessel is between 3 and 3.5, the C statistic is 0.91, but the cutoff that correlates with the physiology 2.8 is not anymore 4. But when the vessel is below 3, all the values that we find out with IVUS are totally meaningless because they do not correlate at all with the physiology. And this is another point to keep in mind before going ahead with the case. So the second question is, it would be nice to have a direct, interaction with you, is what is the biggest pressure drop at this level if we make physiology? And I show you where is the biggest physiology drop. I first use the FFR with adenosine 0.55. That means a huge ischemia. But the point is there any discrete lesion, or is just matter of a very diffuse disease? So to understand this point, we need to do the IFR because of the consideration that I did before, because if we have multiple lesions and I have a pullback with the FFR, I can to rely on the intermediate evaluation of FFR because I have distal lesion that restrict and constrain the increasing flow, and that underestimates the severity on physiological ground of the different lesions that we can find at the level of LAD. On the other hand, totally different story if we make the puzzle in basal condition, what I used to call eye scout, but the company tell me every time that I have to call IFR scout, but it's the same, it's shorter, I scout. But the point is that if we move pulling back the wire of the IFR, as you can see, there is a big jump from a 40 to 80 at the level of the distal part. And this is, what you can see between the two red lines. There is the expected value of IFR is 0.81 at this point, the yellow bar. When we pull back again, we have another jump with a predicted value that is 88, more or less, and another jump proximally. So we have a very diffuse disease. So what I did is to start fixing this lesion, starting distally at the level of LAD, and I make another reassessment. The FFR was still positive, 0.76. During the pulling back, as you can see with the IFR scout, 0.81. There was a jump at the level of the mid-tract of LAD after the sector branch. The predicted value is 0.90. I cannot see because I have a label over this number. And another step up that is at the level of the proximal LAD. So again, I did not remember why, but we decided to treat proximally, just proximally, because we were, trustful that it might be enough to reduce the ischemic burden. In this case, this was the result. It was not bad, but let's go back to the physiology. And again, the FFR was still positive, 0.78. And during the IFR scout measurement, 0.86, that means positive, with a step up that is at the level that, the segment, the disease segment, that I knew from the very early beginning, but for some reason that I did not decide to treat. But I had to treat if I want to fix, the reduced significantly ischemic burden of this patient. So this was the last sentence. We placed the result angiographic. It was really not too bad. And this is, the new function evaluation, 0.9, 0.95 the IFR, so I was quite happy about the result. This is just a summary of this part of the case, 0.31 IFR with a predicted value after the first step, the distal part of LAD of 0.81 and effective actually, the real value was 81 after the reassessment, after stenting, after the stent of the distal part of LAD. Again, there was a step up proximally, and the predicted value that here you can see that again is respected with the further evaluation of IFR 0.86, and we ended up with the last stent in the middle part of the LAD. And the predicted value at this point should have been 97. It was in reality 95, so it was really reproducible. This case, it is just one case, but we have a paper also, Niger Justin Davis on JCC, cardiovascular intervention 2014, that shows the predictability of IFR results. And the main concept is that you don't have, the evaluation are in basal condition, so you won't have any remarkable change in flow after you start to fix, distal lesion in a given vessel. And you get a total different story from the FFR that do not permit that. And I'm going back to the concept that this is one of the reasons. I'll show you other two cases that are two total different story. Why I should call IFR an evolution is not just another way to look at the same story. Okay? And let's move to the right coronary artery. The FFR is 0.76 and 65 was the IFR in basal condition. The first step up was distal, and the second one that was really huge was proximal, and the level of the proximal RCA. So we decided to fix proximally first. You might agree or disagree, but this is not, probably the issue of this of this meeting together. The point is that what we got by the previous test and concept and basics of this measurement is it is easy that we have a red light when the FFR is above 81 and the FR is above 89, green lights when we have below 85, 80 and below 89, but we have some, yellow, gray zone, yellow lights when we have an FFR that is negative and the IFR that is positive. But let's try to explain why we could have that, because we need to explain, we need to at least to try. In this case, the FFR was negative, and we decided, because we had the IVUS, this is the same case of the LAD that I showed you before, we had the IVUS on the table, so I decided to go also with the IVUS. And as you can see, the lesion is very, very tight, and the minimal lumen area is 2 millimeters square, with a reference vessel it is 4, so for sure there is a very tight lesion. So I decided to treat this patient. Even though the IFR was positive, the FFR was negative for the following reason. Angiographically, it was really a tight lesion. Great plaque burden, and as we know, it matters in terms of progression and in terms of, evolution in terms of acute coronary syndrome. The patient was not a drug-naive patient. The patient is on board at least 5 cardiac drugs in terms of aspirin, ACE inhibitors, etc., etc. There was not drug-naive and statin therapy. So I would not expect in a huge amelioration of the clinical condition of the patient. And finally, the cons to treat was the FFR might not be reliable because of distal PDA subocclusion. So this last point is extremely important, because going back to the case, to the coronary lesion before the crack, so the right coronary artery, the FFR was negative, but as you can see, very distal on the posterolateral and descending posterior, there were 2 lesions. And as I said to you before, when you have a lesion that is downstream, the site where you evaluate the FFR is not reliable at all, because you need the vasodilatation, etc., etc., etc. So we decided to treat the patient. This was the final result. It was more than acceptable. And here you can appreciate the 2 very distal lesions on the level of the posterolateral and the semi-posterior. This is the IFR scout, is 92. It was quite reassuring, so the things were well, and we can finish the case like that. This is the last slide, just to sum up, like the previous one, all the things that we did for this case. 65, we fixed first the proximal part, where we found out the big jump, okay, right on the panel. The predictor IFR was 89, and actually the value that we found was 88. There was a distal lesion. We fixed also this part. The predicted value should have been 95, and actually it was 92, so quite reproducible again. So, before concluding this very complex case, moving to the next 2 that are shorter, but I think very interesting, because I think are very new in our world, not still properly described, and it's going to be a pleasure to share with you. I would like to conclude with this last slide. By FAME, Sant'Anna study, R3F, and post-it. If you use physiology, you will change, the treatment enough for the patient. And it is extremely important to keep in mind if you want to reduce, the number of the stents that you implant on the stent, and all the adverse events related to the fact that you are going to implant 7 to 8 metallic platform within this patient. Case number 2, let's move. 66 years old patient. This is the ECG. This is the stress test of this patient. It was considered positive at really high workload, 100 watts. This is the angio. left ventricle. It is not interesting. The right coronary artery, it seems to be clear. Mild to moderate lesion. And this is the LAD. So the stress test was positive, the patient was symptomatic, etc. How to treat this patient? What to do with this patient? These are two other different views. So where would you treat, where would you stand, if any, because we don't know if we have to treat this patient. But the point is that we know everything about this point, when we have to avoid to treat, when we have to treat. But let's make physiology in this case. Interestingly, the FFR value was 0.68. That means that we have to do something to this patient. Theoretically, we have to do something to this patient. Pulling back, the FFR is 82. That means, based on the previous consideration, that the main problem is the distality of LAD, because there is a myocardial bridge. This vessel is within the myocardial wall, within the septum. But, as I said to you before, if you consider this part as a lesion, is not a fixed lesion, but is a dynamic one, you know, the concept that I previously shared with you are still there. When we have a lesion that is downstream or distally to the portion of the coronary artery where we make measurements and the evaluation in terms of fraction for reserve, this fraction for reserve value is not reliable. So, going back, here you can see that the FFR proximal is 1. But let's move to the IFR. As you can see, it's 0.77. Then, pulling back at the level of the bridge is 89. And it's, the value increased to 95 proximally. So we have two lesions. One it is fixed proximally, and one distally, and one distally. Okay, this is the diastole, this is the systole. As you can see, there is a milking at the level of the bridge, distal to the LAD. This is the I-scout, the IFR scout again. Here you can see the first jump, myocardial bridge, 77, 89. Second jump, 94. In this case, we have a patient is symptomatic with a stress test that is positive. We cannot fix the myocardial bridge because we need to stay away with the use of stent or other things, etc. at this level. And I just say also that most of the time also the surgery tool is not needed in this case. But what we can do is to reduce the ischemic burden at the level of the proximal part. Just, to reduce the combination of the dynamic and fixed proximal lesion. So we decided to fix the proximal part with a Promos Premier 3/12. This is the final result. Here you can see the myocardial bridge, the deep encasement of the distal LAD, and this is the functional assessment now. This is before 77 and after the stent of just the proximal part. As you can see, still we have some kind of ischemia, 89, but to be honest, this is really a kind of trivial ischemic burden, because we have reduced this significantly by fixing only the proximal part, but we are aware that this patient might have anyway some problem in a functional test that with increasing workload might be still positive, but for other reasons. This is the proximal part. Okay, I think we can move to the case 3, that is a sort of wrap-up of the first two. I think it's going to be, interesting for you. Male, 63 years old, unstable angina, because the patient has, unpredictable episodes of angina. This is the spec. It is clearly positive at the level of anterior wall, clearly, resting compared to stress. This is the basal condition, left ventricle in basal condition. This is the right, and this is the left. Other two views. Here, what you can see is there is again, there is a huge myocardial bridge, a huge and long myocardial bridge at the level of mid-distal LAD. This is the still frame, and the functional evaluation, FFR 82, was negative, okay, because 80 is the cutoff, or 75, whatever you prefer, negative. The IFR is positive. Again, yellow lights, what we have to do, and how to interpret these two different values. And this, again, just to understand that it is not just matter of, which test is better, but we need to understand why these two values are different, significantly different. So I decided to go with the dobutamine, 20 micrograms, and here you can see that the increase in the milking of the nil LAD. This is a still frame. In systole, as you can see, it is almost an occlusion of the myocardial bridge. And the FFR value is improved. This is counterintuitive. It's improved, the FFR. And why? How could we explain this point? Especially consider the fact that the IFR value is worsening. That means that IFR clearly shows that the patient has a significant, a really remarkable ischemia. So we have green light following the IFR assessment of the physiology, and red light following the FFR. But what is strange is the FFR from, just with adenosine was 82, with adenosine plus dobutamine is 92. Even though angiographically, the lesion is absolutely worsening because we have almost an occlusion, as you can see in this panel. How do you explain that? It is simple. It is simple, but not simpler. Not simpler, because as you can see in a yellow curve is the distal pressure. As you can see, the pressure is ventricularized. This is interesting, because the distal pressure is higher than the pressure at the level of the proximal part of the bridge. That means that when the bridge closes the flow and reduces the flow, the distal pressure is higher than the proximal one. And we can call this phenomenon as overshooting plus ventricularization. In this case, if we inject beta blocker, as you can see, there is almost the disappearance of the overshooting, still remain the shape of ventricularization. And again, when the heart rate goes down and there is not an occlusive, there is not anymore any occlusive milking, as you can see, the two curves still goes back to the two different aortic waveform. And this is interesting, because by CT scan, this patient has a huge, very long myocardial bridge and the encasement, deep encasement at the level of the proximal LAD. I think that this part is really neglected in literature, and I think in 1 month it's going to be published, this paper on JCC. This is a review topic of the week, titled Left Anterior Descending Artery Myocardial Bridge, a Clinical Approach, in which we describe all these type of different clinical scenarios that you might have with the myocardial bridge, depending on how deep is within the muscle, how long is, which is, the mechanical coupling with the muscle, the heart rate, the infusion of drugs, and many, many other things. This is a picture of the paper, but let's give a look at this graph. Because going back to the physiology, in the left panel, as you can see, the coronary flow, when you have tachycardia and non-myocardial bridge in the blue line, the solid blue line is very high, an increase in coronary flow. When you have tachycardia but severe myocardial bridge, the increase in coronary flow is really blunted to half of the initial value or supposed value. Again, this is not when you have a milking, it is not true that the flow is just reduced during the systole, but it is also reduced during the diastole, because when you have this kind of a severe milking with a reduction of flow, what you have is a delay in subendocardial flow compared to the subepicardial flow, the right panel. That might be also 10 seconds. So you need, 4 to 10 beats before having, a full perfusion at the level of subendocardium. So, in other words, the bottom line is that when you have a significant myocardial breach and you have a significant tachycardia, a significant increase in contraction, it is true that what you see is a systolic phenomenon, but also the diastole is compromised. The diastolic flow is compromised. This is another typical example. Diastole, basal, the abdomen stress, systole. As you can see, there is an increase in the narrowing or the intramyocardial, in the tunnel LAD within the myocardial within the septum of the left ventricle, and here the basal and the abdomen stress evaluation. Again, the IFR was positive and the FFR was negative for the reason that I told you before, because considering the fact that the FFR value is a mean of systole and diastole, during systole you will have an overshooting that dilutes, the functional meaning of the myocardial breach that you assess during diastole. On the other hand, the IFR evaluation is just a diastolic evaluation enduring the wave-free period, in which the resistance is close to zero, and is really more physiological evaluation of the diastolic flow that is what matters in terms of coronary perfusion. And this is important to have in mind before, taking decision just based upon the fact that the FFR has been more extensively studied, is a very well established index. This is true, but only for fixed lesion, not for dynamic one. For dynamic one, you need to isolate the diastolic part, and the FFR cannot isolate the diastolic part because it's a mean of systole and diastolic bit evaluation. This is the example that you might show within the paper that is going to be published on JCC about the overshooting ventricularization of the pressure drop. So I think we have, we can finish now. I'm really open-minded and looking forward to hear from you. All the question, discussion, criticism. I'm really open-minded. I have a lot to learn, and I hope you can help in this goal. Okay, I do really think that the things are like that. Thank you, everyone.
Thank you, Professor Tarantini, for this fascinating presentation. What you've demonstrated is how PCI can be refined from the per vessel level right down to the per lesion level, a remarkable advance for the field. So we've had a great response from our audience. So if it's okay with you, Professor, I will dive straight into some questions.
Okay, sure, perfect.
Great. So the first question we have is, what is the uptake and use of coronary physiology in your own lab?
Okay, my uptake is more or less 15%. Throughout Italy, it's more or less 6 to 7%. It's a little bit lower than other countries in Europe, UK, for instance, and Netherlands also. But to be honest, in our lab, it's 15% because especially when you have three vessel disease, etc., to stay below also the standardized cost of the procedure to avoid to implant 10 stents in a patient when the patient is refused from the surgeon, to minimize the number of stents, it might be useful to use this new index that is the IFR Scout, etc., to minimize and to properly understand the anatomy and physiology in any given patient.
Of course. And do you feel because IFR doesn't need hyperemia that it's quicker for you to perform?
Yeah, this is sure. This is for sure an important issue, but I would say that besides the fact that you can go more faster and faster, the point is that when you induce hyperemia, you might have a sort of interpatient and intrapatient variability according to the dose of adenosine that you use. You cannot foresee, and sometimes you have to induce the AV block to be sure that you're getting the maximum dosage that this patient is able to, to afford and to have. So there is a lot of variables that you cannot account for. On the other hand, by estimating by FR, the basal flow, etc., is not different for, lesions that are up to 98%, I say. So it's more stable, I think, as measure. Absolutely, we need to wait for the upcoming trial that will include more or less 2,500 patients that are going to be presented this year. I don't know exactly if it's ECT or ECC, but we have to see. But, basically on terms of biological plausibility and physiology basics, I think is a step forward.
Exactly. So you're effectively removing a variable from your measurement without having to give that hyperemia. And do you use predominantly intracoronary adenosine or intravenous adenosine? Do you have any opinion on which you prefer?
Yeah, this is also an important question. I would say that intracoronary might be okay when you're assessing a single vessel disease with a single lesion, for instance. You don't need, to wait too much to see which amount of hyperemia can you have to make a pullback, etc., because the picture is quite clear. You have an intermediate lesion, a single lesion in the middle AD. In that case, you want to know if you have to proceed with PCI or not. A total different story is when you have a multi-lesion in a single vessel, or, in a single vessel or multi-lesion in multivessel disease. In that case, when you have also collateral circulation or venous graft, etc., you need to understand a little bit more the physiology, a more stable way. In this case, I would prefer to go with intravenous injection. That's my view. Huh?
Sure. And when you're doing a pullback with either, say, FFR or indeed with IFR Scout, and you identify a focal pressure loss which you want to stent, do you still feel that you have to stent normal to normal, or do you feel this concept is no longer valid with the new techniques we have?
Yeah, this is a very important question. It takes at least 2 minutes to answer. I'll tell you why. Because when you get a pullback with the FFR, you're able to detect the more distal lesion. It is not possible to discern when you have something that stay in between or, behind another lesion that stay very distal, because, for the same reason that I spoke and I explained during the presentation. So the pullback for me is not appropriate to do by using FFR. On the other hand, considering the fact that you don't have any impediment in terms of increasing flow, etc., because you don't need it. When you make an estimation in basal condition with the IFR, the pullback is really reliable, as I showed you in the previous slides, etc. So in that case, I will trust a little bit more on which, if the patient has a lung disease or has a multi-lesion in the context of a diffuse disease. The answer is a little bit more difficult, and this is why we can comment also about the future trial and the negative impact of FFR-based revascularization. The point is that when you have a diffuse disease with 2 or 3 bumps that are trifocal lesions, but in the context of very diffuse disease, you need to be very careful to place a stent, a focal stent that is under dimension, because in that case, you may, have stent thrombosis because the angioplasty is suboptimal. So when you have a very diffuse disease with 3 or 4 bumps, you need to go, I think, with IVUS and to optimize the PCI. If to optimize the PCI, you need to go longer, you have to respect this rule. Otherwise, you might have an increase in stent thrombosis. I don't know if it is clear what I said.
No, it is. And I think you make a really important point that IVUS and coronary physiology are not the same thing, and they don't give you the same information. And it's really interesting to hear that you use both of those methods in a complementary fashion to achieve the best possible PCI for your patient. And do you have any experience of the new IVUS co-registration that is soon to be available?
Yeah, we have the Sync Vision you're referring. We have experience. It is a nice tool, not only for the co-registration, but also for the possibility to make a zoom, of the balloon, to do a nice QCA. So it's a nice toy to have in the lab, I think.
And we've mentioned almost exclusively talking about pressure-based coronary physiology, but we've got a nice advanced question from one of our viewers. And they want to know, what's the difference in practical terms between FFR and IFR versus a flow-based index such as coronary flow reserve?
Yeah, to be honest, I don't trust too much in coronary flow reserve. As you know, it is a nice story that started with Lance Gould. It is quite typical of all the non-invasive tests, but the point is that when the patient has an ischemia or angina, we need to discern between 2 compartments, that is the epicardium or microvasculature. This is a very important answer that we need to give to the patient before treating it, because by PCI or CABG, what we used to do is to skip a lesion that stay in the epicardium. So I think that is extremely important to have on board for this kind of patient when you have doubts, to have a parameter that is a lesion-specific index. That's, imply reduction in coronary flow reserve. I think it's not important beside the general prognostic factor and the use of ACE inhibitor, statin, etc., to know if there is a problem in microvasculature. We need to know during and before PCI or CABG if the reduction in coronary flow reserve is related to the lesion, to the epicardial lesion. So that's my point.
Sure, thank you very much. And we've got a few more sort of practical-based questions now, which are, do you systematically check for drift at the end of your pressure pullback assessment?
Yeah, I think that to say always and never is always a wrong thing. So sometimes if I perceive by looking at the picture, the curves, etc., that there is something wrong, to get the wire a little bit, into the catheter and to equalize again to check twice if there is a drift is important, I think, because you need to be extremely sure on the result that you have.
Sure, absolutely. And do you have a particular threshold for drift that you would consider repeating the measurement?
If I see that there is the risk of a drift, even a small drift, I prefer to equalize and to get rid of it.
Sure. And a common question now that a lot of operators have is, do you feel confident to use the pressure wire itself to deploy your stent?
Basically, what I think is, as I've shown during the presentation, I think that if I have to treat the patient, is the role. What probably, but how is, I think, is matter of IVUS.
I see. But are you actually delivering balloons and actually doing the stenting procedure on the Verata wire itself?
No, I don't used to bring the balloon over the wire, no. I don't use it. On the wire, the pressure wire, I don't use it.
Sure. And our last question here really is that with the advent of IFR and the quickness and the ease of use, do you find that you're now performing post-PCI IFR measurements in more of your patients?
Yes, what I said is generally, my answer is not always, sometimes, to be honest, because we prefer, if we are going to treat proximal segments like proximal LAD, circumflex left main, when we have decided based on physiology that this case deserves a treatment, we prefer to optimize by using the IVUS.
Fantastic.
We don't have data. We have to admit also that we don't have data, except for the FFR. We have some very old study that says that the result is fairly good if you are above 0.90. I don't have number for the IFR, but in general, I prefer to see the result in terms of MLA by using IVUS.
Fantastic. Well, thank you so much, Professor Tarantini, for answering our viewers' questions. It's been a real pleasure having you with us today. So thank you very much for joining us.
Thank you all. It has been really a pleasure, and I hope to see you soon around some, meeting around the world. Thank you.
Absolutely. So everybody, that was Professor Tarantini speaking to us live from Padua University in Italy about how he is using IFR and IFR Scout coupled with IVUS to simplify the diagnosis and treatment of even the most complex forms of coronary artery disease. You can find out more about Professor Tarantini in the link under this video. So it just remains for me to say thank you, our audience, for joining us today. As ever, we would be very grateful if you could please rate this webinar using the star rating system on your screens. If you have enjoyed this learning experience and want to listen to our other webinars, please turn to the Academy section of our website at radcliffecardiology.com/academy/webinars. So that's all from me. Until next time, thank you and goodbye from Radcliffe Cardiology.